So SIADH, it means always increased ADH. It means, that's what you should remember. It means syndrome of inappropriate ADH secretion. But what does this mean, or why inappropriate, I'll tell you at the end, okay? And their main complaint is, I'm resorbing lots of water. It's just the same as they would drink water, okay? It's sort of a light intoxication by water. You can really easily intoxicate yourself if you're going to drink 3 liters at once. It's very dangerous. You're going to have brain edema immediately. Edema of all cells, but over here, brain is the one which is in danger because brain is closed in the skull. Okay, so never drink 3-4 liters at once. You can die. And pretty similar is when you're having SIADH, although it is not as instant, but you are still resorbing all the time free water and you're having brain edema. Okay, yeah. So, and what are the symptoms? First, it's going to be headache, and then it's going to be, it can be seizures, and then it can be coma. Okay, yep. So that's SIADH, and those are the main symptoms. And you know what? It's not in old books, the SIADH, but now we see in light version it's everywhere because the cause could be basically anything. And it's very interesting, but remember 2 organs. Remember brain. Oh, that's not a right brain. So, well, okay, so brain, 2 organs, and lungs. And I could also mention, for example, pancreas, but remember mainly these 2 organs. And I can tell you one thing. I could name you many causes, but just remember, if you're having a trauma, so brain trauma or lung trauma, suddenly the cells of the brain or lungs, they will produce ADH. Okay? And it could be trauma to both of the organs, trauma, it could be inflammation. So if you're having meningitis or encephalitis, or if you have bronchopneumonia, bronchitis, if you have bronchitis, we see suddenly that the lung cells or epithelial cells of the lungs are able to produce ADH in higher levels, okay? And it could be tumors. So tumors of mainly brain and lungs, okay? And yeah, and still back to infection. If you have pneumonia, if you have tuberculosis, if you have Legionella, everything can sort of stimulate the lungs to produce ADH. So brain and lungs, remember, the main organs, which can give you increased levels of ADH, sort of uncontrolled levels of ADH. But also some drugs do it. And as I said, also, for example, if you have pancreatitis, you can have increased ADH levels, or tumors of the pancreas mainly. They can produce ADH as well. And all of this causes what? That you resorb water, free water, and the water gets into the cells. So you don't have interstitial edema, you have intracellular edema, okay? And the organ that's going to complain, the first is the brain, okay? And you know what? As I started, SIADH is something similar to be intoxicated by water. And you have this psychiatric disease, which is called psychogenic polydipsia. And psychogenic polydipsia means that you are nuts and you're just drinking water. Okay, it's a disorder. It's a psychiatric disorder. And they drink like 10-20 liters per day. And what this will What this will cause? This will cause that all of your ions are diluted, and that you have polyuria because you're drinking a lot, that you're going to pee a lot. Okay? Yep. And what's the difference compared to SIADH? Because these people are not drinking a lot, in a way that they're just retaining water. They cannot get rid of water because ADH is functioning all the time. But how will their ions be? Will they be diluted as well? Okay, so in both cases they have hyponatremia, hypokalemia, hypopotasemia, okay, or hypokalemia, hypocalcemia, okay. So they're both diluted. But in case of psychogenic polydipsia, where the problem is psychiatric, the systems are working fine. So in case of psychogenic polydipsia, how would you expect that the ADH levels would be? Low. Decreased. Very low. Very good. So you are hypotonic, so the levels of ADH should be decreased. And that's the way it should be. That's why they have polyuria, and also they pee diluted urine. Okay? And that now we're coming to the term inappropriate. Because if you check patient with SIADH, his ions are all diluted. You're retaining water, but still you are concentrating urine. Still the ADH is high. That's why this is an inappropriate response. And that's why it's inappropriate secretion of ADH. Because if everything would be under control and you are diluted, you are hypotonic, you wouldn't ever secrete ADH. Get it? That's why the term inappropriate. And you are inappropriately concentrating urine. You should get rid of water, but you are not. That's why SIADH. Everyone understands? Yep. So that's one.
So regardless of the tonicity problem, you still concentrate urine.
Yes.
That's what it
yes.
is, right?
Exactly. Okay. Regardless, I mean, if you would be hypertonic, you would concentrate or you would retain water. But you are hypotonic and you are still keeping the water. So this is inappropriate. Okay?
Appropriate. Okay.
Good.
So isn't this related with diabetes insipidus?
No. No. This is just the opposite to diabetes insipidus. Okay? So watch out. So this is SIADH, increased levels of ADH. And we're going to get to decreased levels of ADH. And now is the time for diabetes insipidus. So first it was example of increased ADH, and now you're getting to decreased ADH. And this is diabetes insipidus. I hope they're two P's. I don't care. Doesn't matter. So diabetes insipidus. No, I mean, I guess one P. But you got two types of diabetes insipidus. Diabetes means polyuria, that you're peeing a lot all the time. And you have two types. You can have a central type and a peripheral one. So if it's a central, this again can be trauma. It can be apoplexy, okay, bleeding. It could be, or in a way, stroke. After surgery, if they're pulling, I mean, it's going to be a surgery of pituitary gland, and they're pulling with the hypothalamus. Suddenly, and typically for several days, fortunately, the levels of ADH are decreased. And that's why you are losing free water. You're losing water. You're having polyuria. Okay? And basically, people with diabetes insipidus, doesn't matter if it's central or peripheral one, that's the second type, you call them that they live, or you say they live between a toilet and a tap. They first pee and they have to go drink. And if they will not drink, they will get dehydrated and die. They can get into shock, circulatory shock. Okay? So they're instantly peeing and drinking and peeing and drinking. Okay? Yep. And so we got central type, no ADH produced, or we can have a peripheral one. And the peripheral one could be inherited or acquired. And the peripheral one means that the problem is not the ADH itself. Actually, paradoxically, over here, the ADH levels are high, but the receptor is not working. And inherited, it could be, of course, inherited mutation of the receptor. Okay. Yeah. And so inherited, that's rare, but this is pretty common, acquired. And typically, remember, please, if you have long-term hypercalcemia, maybe because of a tumor of a bone or hyperparathyroidism or whatever, somehow the calcium interacts with the receptors in the kidneys and causes peripheral diabetes insipidus. So it malfunctions the receptors. Or if you have long-term hypokalemia, this also causes peripheral diabetes insipidus. Fortunately, these are very likely reversible. Okay? But every time you're going to get a patient and he has hypokalemia for a long time, slight, if it would be severe hypokalemia, he would die on arrhythmia. But if you have someone with long-term hypokalemia or long-term hypercalcemia, suddenly now they can have polyuria due to diabetes insipidus, the peripheral type. Okay? Okay? So remember, central type, I'm not producing ADH, or peripheral one, but in either of cases you are you're getting polyuria and also polydipsia because you're drinking. Okay, and what is this similar to? It's very similar again to psychogenic polydipsia in a different manner than the previous example. Okay, so in psychogenic polydipsia, that is similar in other way to diabetes insipidus, and that is that you're peeing a lot and you're drinking a lot. But in case of psychogenic polydipsia, the cause is because first you're drinking, then you are peeing, and everything is diluted in you. But in diabetes insipidus, you are first losing water, so it's rather going to be concentrated. You're having a hyper osmolarity, and that's why you go and drink, because you're thirsty all the time. Okay? But if you have two people which are peeing a lot and drinking a lot, and they come to your office, what will you ask them? And from their answer, you can easily tell, or will help you to decide if this is a psychogenic polydipsia or diabetes insipidus. And the magical question is your polyuria getting better during night? And if they say yes, it's rather psychogenic polydipsia, because you don't drink in the night. So if you don't drink as much, you won't go peeing. But in case of diabetes insipidus, they pee all the time, so they have to go drink. Okay? So that's the way how you can tell. And there's still one more thing about diabetes insipidus, and that is that one of them you can efficiently treat. And basically, it's also a test if it's this type or that type. and that is if you artificially give ADH. You give it under the tongue typically or into the nose. And if this works immediately and the patient starts concentrating urine, you have the central type, okay? It's the central type. If it's not working, it's the peripheral type, okay? So, that was ADH. So, thanks for watching, and don't forget to subscribe and ring that bell. And as always, check the description below for supplementary questions and other materials.